afternoon. Let's see what I'm wearing. It is that even healthy people fall from ladders. That's where I was on a ladder Saturday night. Very top of a large high ceiling room, a closet. I had all these prints stored, and I promised to donate one for an auction. So Saturday night, I said, oh, before I go to bed, I'll have it, then I can package it Sunday. You know. I went up the ladder, brought it down, went up again. It's a very rickety ladder. On the way down, I noticed it's wobbling, and then the next thing I know, it's going that way. I'm going backwards, and in slow motion, I kind of rotate and do a judo fall, where you break the fall by slapping down with your forearm, and then you kind of roll. So I said, thank God I didn't break my head open or my back. My arm was very painful. Wiggle the fingers, good, but I couldn't flex or my wrist. Packed it in ice. I couldn't get an x-ray at USF until Monday, so I went to an urgent care center. They did it, a brand new one right near my house. Sure enough, I had a fracture of the radius and I had to wear a cast for X amount of time. Ironic, because this hand has been out of commission for 3 months because I had a repair of this thumb joint. So now this is almost back to normal. And I have this. So anyway, I'm going to talk about apathy and depression and anxiety. Now, I know what depression is, but here's the problem. The depression and Parkinson's disease has a lot of overlap, and that one feels tired very easily, fatigues easily, feels somewhat down. This is just a superficial comparison, but depression is kind of, we consider it part of Parkinson's disease. But apathy is not really clearly defined or well understood. But as you'll see at the end of this review, apathy is a component of the psychological profile of Parkinson's disease. And since I don't often talk about apathy, I actually am going to use a guide so I don't go off. So I'm going to explain the differences between apathy and depression and why apathy is such a problem in PD. And what are some treatments for depression that actually worsen apathy? And tips for improving apathy. So we know that in Parkinson's disease there's a whole spectrum of neuropsychiatric issues, depression, anxiety, and apathy. And the interesting thing is that there's an overlap, just like between depression and Parkinson's disease, the overlap between depression and apathy is significant. And one of the ways to think about it is that depression is a problem with mood. We all have experienced a spectrum of depression, from feeling a little down, a little blue, a little sad, to very severe depression where one does not want to get out of bed, one feels isolated, doesn't want to do the things they used to do, and then there's bodily symptoms of can't sleep or too much eating or not enough eating, that kind of thing. And so it's a mood disorder. It's categorized as a problem in mood, how you feel, depression. And it has some bodily manifestations, mostly problems of sleep. And this physical fatigue and malaise. It also colors your thinking. The mood of depression makes it difficult to perform in, say, a cognitive test, a test of your thinking, say, memory, abstract thinking. When those tests are given to someone who's depressed, they score terribly. They score in the dementia range. Dementia being a cognitive problem, a thinking problem. And people who are depressed, who take this kind of test for thinking, often have a pseudo-dementia. It looks like dementia on the testing, but it's because of depression. So depression, as you know, we had a session on that already. Now apathy, how it differs, is in terms of its origin, is that it's a problem of motivation. It's primarily an issue of motivation. No desire to do anything but to sit apathetically, not feel anything. Lack of feeling is what it refers to, without feeling. Empathy is you feel for others, and Apathy means no feeling. You feel completely. I'll give you an example of some apathetic behaviors. And this, as I say, is a disorder of motivation. What is motivation? Wanting to do things, having targets and goals, and being active and accomplishing them. If you don't have any motivation, you just don't move. The word mote comes from motor, to move. What moves you? What motivates you? So think of the origin of the word. So it's a disorder of motivation, so there's difficulty in initiating movement. Sounds like Parkinson's. Well, any activity, difficulty initiating any activity. Low activity levels in a range of things that you used to do, the activity is diminished throughout all the things you used to do. Less interested in trying or learning new things. Lack of effort or reduced productivity. Not completing tasks that were started. Lack of interest in socializing. That's one of the common things that you'll see in apathy. Don't want to see your friends anymore or be around family or anything. You just want to leave me alone. Don't even say that. You just isolate yourself. Not concerned about the issues that you used to think were important. And you always need someone to remind you or prompt you or goad you to move. Now, we like to think of it really, I said it's a disorder of motivation, but it's really a syndrome. And you know from my talks, syndromes are collections of signs and symptoms. It's a combination of them. And so apathy, which we can define as lack of motivation, a failure to initiate goal-directed activity, is cognitive, emotional, and behavioral. Those are the three kinds of symptoms. That's a syndrome. So the cognitive means there's no lack of curiosity, a lack of interest in terms of what is the meaning of things. You know, that's what drives so much activity is curiosity. Well, that's the cognitive aspect of the syndrome of apathy. I said apathy is a motivational disorder, but it's also considered a syndrome. So lack of interest, lack of curiosity is the cognitive or thinking component. The emotional component is there's reduced emotional reactivity. No, reward doesn't seem to work. You have no feelings of well-being, or nothing turns you on, so to speak. And the behavioral component is reduced initiative. You need others to structure the activities. In fact, that's how you manage apathy. You need someone in the family or a caregiver that structures the day. So they're doing something throughout the day. If you leave it up to them, they'll do nothing. And many of you who live with patients with Parkinson's disease and many PD patients themselves know that it's hard to get motivated. That's part of the Parkinson's disease. But it's the apathetic component of it that is responsible for that lack of motivation. Well, is apathy exclusive to Parkinson's disease? No. It's very broad. It's found in, it's in Alzheimer's disease and strokes and many other conditions it can happen. And anything that affects the brain might produce apathy, and a whole range of psychological, psychiatric issues can have apathy as a component. And when there is apathy in these disorders, what does it imply? Well, typically it increases the caregiver's stress and distress. The outcome for the illness is poor. When there's, in addition to the illness, there's also apathy. The outcome is not positive. Terrible compliance with treatment. So a doctor spends a lot of time coming up with schedules of medications and activities. Patient with apathy, unless they're structured by their caregiver, will not be compliant with medications or any activity. And if they have to go into rehab because of the illness, the outcome is really terrible if they're apathetic. There's a study that I just summarized quite nicely where they looked at the amount of time in various activities, spent in various activities. For example, cooking, TV, reading, computer, gardening, outdoor activities, hobbies, solitary conversations. And the apathy group spent almost twice to three times as much in front of the TV than the non-apathy group of PD patients. These are PD patients. So there's the people that were diagnosed with apathy, they were couch potatoes. They spent a lot less time reading than the no apathy group. They spend a lot less time gardening, a lot less time with hobbies, a lot less time with almost everything you can think of, except a lot more time alone. That's where they exceeded the non-apathetic patients. There are many ways to measure apathy for researchers, and it's amazing. I didn't realize there's at least 6 different rating scales when one interviews a patient to see how apathetic they are, the extent of apathy. And it's important for research because if you want to develop treatments for this, you need to know how to measure it. You can't just say, do you feel more motivated? That's not enough. And there are about 4 questions in the standard unified Parkinson's disease rating scale that relate to apathy. But there's a pretty significant extensive apathy scale, so I'm not going to get into them. And we also rely on self-reports, family rating, and clinician ratings on some of these scales. They only recommend using 2 of the scales for research. I'm going to keep on going. Okay, what's the prevalence and incidence? Prevalence means how common is apathy in the PD population. Total number of PD patients and what percentage of those have apathy. And what is the incidence? Is the number of new cases of apathy diagnosed per year in 100,000 patients, for example. And it depends how it's assessed. So people have said that the prevalence is from 12% of the PD population up to 70% of the PD. So it's not really clear because it's not measured extensively. And it's really a tricky business because there's no formal diagnostic criteria in the Diagnostic and Statistics Manual in Psychiatry for apathy. It's psychologists who focus on it. Interestingly, we have had 2 graduate students that worked with us in our movement disorder clinic, and they did research on apathy, but mostly in Huntington's patients, who are also, it's a neurodegenerative brain disorder, and they also develop severe depression and apathy. They did a meta-analysis, and that means they take all the studies that have been published, pull them together, and come up with a meta result. And they pooled 23 studies, and they found 40% prevalence across these 23 studies, 40% prevalence of the apathetic syndrome. And they looked to see what it was associated with, because they have the complete records of these patients. It's associated with a lower mini mental status exam. In other words, lower that score is, the worse the cognitive function. In other words, dementia. If you have score 22 out of 30 on this mini mental test, you're considered demented. So they tend to have lower. So people that have dementia or score low on this mini mental test tend to have a higher likelihood of apathy. They tend to be older in age than the people without apathy. And there are some proposed diagnostic criteria that's for future research. Now, we'll talk about depression and see how it contrasts, and we'll talk about treatment in a moment. So, there's depression in PD, and that can be up to 80% of the cases that we've seen have depression, and up to 50 to 70%, supposedly, depends on who you read, have had depression diagnosed and treated even before the diagnosis of Parkinson's disease. So it could be depression is kind of a really early prodromal manifestation of Parkinson's disease. Depression, the major depression that can occur, can last for many, many years and occur at any stage of the illness and can persist throughout the illness. However, there's interesting moment-to-moment variations. Like everything in Parkinson's disease, it's not the same. We think of it as a gradually changing illness, gradual worsening of motor function, with a lot of stability if the medicines are taken properly, but there is a gradual decline in motor function. But we know in Parkinson's disease, motor function varies, especially as the illness has been present, from hour to hour, from season to season, from mood to mood. You know, if you're all stressed out, you're going to have a lot more manifestations of the symptoms of Parkinson's disease. So depression and mood can fluctuate just like that. A lot of people are depressed, and then as the drug is wearing off, they start feeling anxious because I'm not going to talk much about anxiety, but it's like this vague fear of anticipation. And in Parkinson's disease, it's often associated with depression. And the drugs we use to treat the depression often help the anxiety. The anxiety can be exacerbated as one is wearing off. People have an end-of-dose anxiety kind of attack sometimes. And then they tend to over-medicate with the dopamine drugs because the anxiety of anticipating an off period is so great. What are the major criteria for diagnosing depression? All you need is 5 of 9 symptoms. I'll go through them so you see how it's different than apathy. Number 1 is sad mood. Well, that goes without saying. Diminished interest. That's kind of overlaps with apathy. Weight or appetite loss or gain. That's not associated with apathy necessarily. Insomnia or hypersomnia. Don't see that much in apathy. I'm talking about what you see in depression. Slowing or agitation. Agitation kind of associated with anxiety. You see slowing with apathy, but not really. I mean, they just don't initiate activity. So, but in depression, there's slowing, fatigue, feelings of worthlessness and guilt, indecision, and a recurring thought of death. Depression in PD, the diagnosis can be difficult because the features of PD itself overlap with features of depression. So, for example, the slowness of movement, the fatigue, the insomnia, the weight loss, the flat mood, the concentration problems can be confused with signs and symptoms of depression. There's a wonderful slide that eventually, maybe I'll bring this up if you come on the cruise next year. Has some nice images. It's kind of advertising the cruise. Okay, so how can we tell depression and apathy apart? There's an overlap between depression symptoms and apathy symptoms. I'm going to go through the depression symptoms in a nutshell. It's like a Venn diagram. There's a circle with all the depression symptoms, another circle with all the apathy symptoms, and where they overlap. So the depression, I'm going to reiterate: sadness, worthlessness, guilt, hopelessness, helplessness, pessimism, and suicidal thoughts. Apathy, decreased initiative, less interested in starting new activities, less interest in the world, emotional indifference, decreased emotional reactivity. The overlap between depression and apathy is anhedonia, inability to experience pleasure, less enthusiasm about the usual interest, and increased slowness. That's it. That's where it overlaps. Why is it important to distinguish apathy and depression? Well, the SSRIs, which are common medications for depression, the selective serotonin reuptake inhibitors, characterized by the classic Prozac, but we use as paroxetine or Paxil or Zoloft. All of these SSRIs we use commonly in Parkinson's disease for depression. However, there was a paper that suggests that a retrospective study of the treatment of depression with SSRIs, and they found that with 181 people with Parkinson's disease, 42% had apathy, 17% with co-occurring depressive symptoms, and 2% with depression only. That was the population. It was mostly, they were looking, it was a study of apathy, basically. So they had 42% of this cohort of patients had apathy diagnosed. This is from the University of Florida in Gainesville. 70% of the patients had co-occurring depression and apathy, and 2% had pure depression. And what they found is the use of SSRIs, but not other antidepressants, was associated with increased apathy, which is quite interesting. So if people are treated for the depression and remain very apathetic, it's very important to consider changing antidepressants. In fact, I tend not to use SSRIs as often in Parkinson's disease. I tend to use the tricyclic antidepressants that are given at nighttime. Number one, because they make you very drowsy. Some of the side effects of these drugs help tremor at night. And 3, it won't worsen apathy, which is something I wasn't familiar with. There's a recent report about this. So I have to pay more attention to people who have no initiative and anhedonia who are being treated for depression, and the family says, you know, they still are isolated, don't want to do anything, what should we do? And there's a number of things we could talk about, the mechanism on what parts of the brain, what neurochemical systems are involved in mediating in the apathy syndrome. So we know that there are two major dopamine systems in the brain. The nigrostriatal system you're all familiar with, because if you don't make enough dopamine in that system, you develop the motor symptoms of Parkinson's disease, slowness of movement, rigidity, tremor. But there's a mesolimbic dopamine system that is the midbrain is like, think of Mickey Mouse's two ears. The substantia nigra is right where the ear meets the face of Mickey Mouse, the substantia nigra. And right in the middle of the face would be the mesolimbic neurons. So the dopamine neurons are around the ears. So I'm just giving you, it's not really the ears, I'm talking about brain. And the midbrain looks like an upside down Mickey Mouse head with the ears facing down. And just where the ears meet the body, that's substantia nigra. Those neurons project to the striatum, both sides. And if you lesion that or you don't make enough neurons there, you have Parkinson's disease. The mesolimbic the cells are in the middle and they go to the ventral striatum, unlike on both sides, and then to the limbic brain, which is the emotional brain. And in that dopamine system is what mediates reward and is involved in motivation. If you were to lesion the mesolimbic system exclusively, you'd have a person who can't be turned on by anything. Nothing, and they become apathetic. If you block dopamine receptors of the mesolimbic system, they become apathetic and listless. And the inverse of that, if you put an electrode in mice into that mesolimbic system, so they can stimulate it by pressing a lever, they press that lever to the point that they die, because it gives them so much pleasure that they stop eating and drinking. Similarly, if you take psychomotor stimulants, they stimulate both the emotional dopamine system, the mesolimbic, plus the nigrostriatal system. So most drugs that stimulate psychomotor stimulants do just that. They increase locomotor activity like amphetamines and cocaine, but they also stimulate the mesolimbic dopamine system and make you feel good and euphoric, and you want to do things, you want to clean house, you want to take apart watches. This is quite amazing, because those are the systems that are deficient in apathy and in Parkinson's disease, the mesolimbic dopamine system. Unfortunately, the treatment for major psychoses, where drugs, the Thorazine generation of drugs, block dopamine receptors of both kinds and produce Parkinsonism plus an amotivational syndrome of apathy. So you see many schizophrenics who are treated with these antipsychotic drugs, they're basically blocking their mesolimbic dopamine and their nigrostriatal dopamine, so they develop at higher doses Parkinsonism and lack of motivation and anhedonia, absolutely lack of pleasure. Now, what about if you give dopamine drugs? Well, it turns out dopamine agonists actually will improve apathy and can lead in some people to excessive seeking, excessive activity, especially gambling, hypersexuality, to the point it becomes so excessive one develops an obsessive compulsive disorder. And you see this in Parkinson's disease, usually as a result of an underlying personality, but a result of the use of the anti-Parkinson drugs. And the apathy scores get higher the greater the disease severity. That's clear. It worsens with motor disease progression. Because the truth of the matter is, we not only lose dopamine neurons of the motor system, we begin to lose dopamine neurons of the mesolimbic system. So as the illness advances, you get more and more apathy, and it corresponds to the worsening of motor function. Even though it's two different neural systems, they're involved in the dysfunction of the dopamine neurons. So what's interesting in this study that they're reporting here, they looked at apathy and depression in PD in relation to their cognitive status, the extent of their dementia, if or not they're demented. So in a population of patients who were categorized as apathetic, about 36% were not demented, but 80% were demented, with 50% not known. So in general, people who have apathy tend to have a higher likelihood of being demented. Now, people who have depression, however, only about, where's this? Yeah, 24% were demented. So there's less dementia in people with depression, although I told you of the possibility of pseudodementia. But certainly if there's apathy diagnosed as the predominant feature, the apathy syndrome, they tend to be more likely older, more advanced motor disease, and cognitive function is less. There's all kinds of tests for research, and I'm going to just recap and we'll end it here. So apathy, lack of feeling, is one way, but lack of feeling you would say, if you're a word scholar, anesthesia, right? It's not that. It's a different kind of mood issue, not a perception of light, touch, pain, etc. That would be anesthesia without sensation. Lack of feeling is empathy. But feeling means emotional feeling, your inner feelings. Sense of well-being, sense of euphoria. The apathy, which is common in PD, is distinct from depression. I've kind of pointed it out, even though there's some overlap. It occurs in both demented and non-demented Parkinson patients. The best cognitive predictors of apathy in non-demented PD tasks are frontal tasks, such as the Stroop. And that's funny, I don't do that very much in Parkinson's disease, but in Huntington's it's absolutely important, because when there's apathy, they can't learn this task, and you can practice it on your own. This is called the Luria task, and the Stroop is very similar. You go knock, chop, slap. If you can do this sequence without any cues, and do 4 in a row in 10 seconds, 1, 2, 2, then that means you have normal motivation, frontal lobes, executive function, but that test correlates with whether there's going to be apathy or not. If you have a problem with that test, that means you have problems with the projections of the frontal lobe, problems with the mesolimbic system, and you'll do poorly on that test. So I'm going to start doing that with my patients. Just have them see how common it is that they can't do that. Now, as we get older in age, just in healthy, people have a problem with this. You have to anticipate the first movement. People can imitate it, but when I ask them to do it on their own, they get the sequence mixed up. I'm trying to finish this recap. Okay, the apathy is also associated with physiological blunting to emotional pictures, and this is something I skipped over, but one of the studies would look at the emotional response, and you can measure that by galvanic skin response, like a lie detector. You hook people up to their pulse, to their perspiration in the skin, and if something hits them emotionally, you'll see changes. Completely automatically, you can't hide that. That's how lie detectors work. They ask you something, and if you're lying about it, it creates a physiological response that the FBI can detect. The likelihood of apathy increases the more advanced illnesses and with age. And that's it. I can take a few questions, but I'd like to end because I left late and I have to have a cup of coffee before I start clinic. But I'll take a couple of questions. Go ahead.
Are there any drugs for apathy?
There's no specific drug for apathy. What can improve it, though, is changing antidepressants that may worsen apathy to one that won't. A lot of people will use for the somnolence associated with apathy or somnolence associated with Parkinson's disease, and the anti-Parkinson drugs can make people feel sleepy during the day, and partly related because of the fact they're not sleeping at night. So medication, what I would do is stop the SSRI if someone has a lot of apathy as we gather that information. Then I would switch to a different antidepressant, something like mirtazapine or trazodone or doxepin. There's 3 choices that we could have. That'd be it. Now for the daytime somnolence, if that's a serious problem, I tend to change the anti-Parkinson drugs because they often are so. But some patients do okay on modafinil, which is used for narcolepsy. And it's a psychomotor stimulant, it's a controlled substance, it can be abused like Ritalin. It's in the same class. It's like modafinil is an amphetamine, basically. So that would stimulate the mesolimbic dopamine system, but I would not give it to people who already have, it might work for some cases of apathy. I have one more question.
Okay, general question, you addressed dopamine agonists. Can you address the difference between Nupro and carbidopa and its effect on?
Well, have you been here before?
Yeah.
Okay. Well, let me confess to you that carbidopa doesn't do anything.
Levodopa.
Yeah, okay. Carbidopa is there to protect levodopa.
Right.
So I'd rather you say between levodopa, which is the natural precursor to dopamine. What's the difference between that and a synthetic dopamine? Because Nupro is a patch that releases a drug that is a synthetic dopamine. What does that mean? Well, levodopa is naturally occurring. It's found in beans and legumes. It's found in all proteins. And it's what the brain uses to make dopamine and to make noradrenaline and to make a number of other anadrenaline. So when you give levodopa in large amounts, you allow the brain to start making more dopamine. When you give an agonist, you're just giving a drug that looks like dopamine, will fit into the dopamine receptors, gets into the brain, doesn't matter about diet. Whereas levodopa, if you have too much protein, levodopa may not penetrate the brain as well. So the agonist, the word agonist is like protagonist, Agonist means it acts on. It acts on dopamine receptors. Antagonist is something that blocks receptors. So an antagonist of dopamine would be, say, thorazine or Haldol, the antipsychotic drugs. They block dopamine, and you can imagine what happens. Now you know, apathy and Parkinsonism. If you stimulate dopamine with a dopamine agonist, you stimulate both the mesolimbic and the nigrostriatal, and you'll improve motor function and perhaps mood and motivation. So one of the treatments that they suggest for apathy is make sure that their anti-Parkinson drugs have an agonist. And I usually tend to use an agonist. It works a little better than the levodopa so now you know that an agonist, no one should ask this here, memorize that. An agonist is a drug that acts directly on a receptor. That's simple as that. And there's a whole bunch of them for Parkinson's disease. Now we use 3 of them. Requip, which is ropinirole, the least potent. Pramipexole, which is the most potent. And that's the one that's known for sleep attacks and compulsive gambling and hypersexuality. That's more likely to do that. So pramipexole may be good for people who have no interest in anything. I would be careful not to make them sex addicts from apathy to obsessed about sex, because that would create problems. And what was the third point? Anyway, that's all I need to say.
The patch.
Well, the patch is a dopamine agonist. The patch is the third dopamine agonist, yeah. Thank you. So it's Requip, Mirapex, and rotigotine. Rotigotine is the name of the drug in the patch. Before that, we still have bromocriptine. Parlodel was the first dopamine agonist that we ever used. And the one that I really liked was called Pergolide, because that one doesn't result in dyskinesias. The other ones may result in dyskinesias, levodopa-like induced dyskinesias. So I think that's it. The Pergolide was withdrawn because it could cause, in very rare patients, pulmonary fibrosis or heart valve fibrosis. So the FDA noted that, and the company withdrew it. Thank you. I don't think the people that come here are apathetic. So I went over your heads, because if you come here, that means you're not apathetic. Or you have a strong caregiver.